Dr. Hewett, if a person has surgical reconstruction versus not, or one type of reconstruction versus another, what are those criteria that are most supported that says that, okay, this athlete is ready to go back into sport? Is it that triple jump on single leg for distance? Is it a lateral for time? Is it a combination of things? What is it?
So here's the bad news. So Kate Webster and I did also a meta-analysis of meta-analyses. Some people have made fun of us on that and called it an inception analysis. It's it is a method used by Cochrane, and Cochrane have used its official name is an umbrella analysis. So we did a meta-analysis of all the existing literature on return to sport programs, criteria, testing batteries, whatever you want to call them. And these are usually the ones you think about, the 4-hop tests combined with something else, T tests, maybe some like a Q's activity form. There are various ones out there that claim to have high validity. What we showed clearly was these don't have high validity. Currently, what we're doing is not good enough. It's not valid for prediction of who is going to go on to a second ACL injury for sure. When we looked at that data, we were surprised when we had all the cases together, contralateral ACL injuries combined with graft ruptures, which are smaller numbers. Actually, you have more contralateral ACLs for second ACL injuries than you do at graft rupture by multiples. But when you put them all together, there's no effect. Passing, well, for one thing, the first thing we showed in that was that the percentage of people who pass existing test batteries is unacceptably low. It's about 23%. It's too low. So that's how many, only 23% actually ever pass the test battery. So if they're going back to sport, they're going back to sport and they haven't passed. Mm-hmm. So the pass rate is actually very low. But if you also look at, well, for example, its ability to predict return to sport, that's okay. If you pass return to sport at 1 and 2 years, you're going to be like, 60% are going to be back a year and 80% are going to be back at 2 years, depending on what level of athlete they are. Obviously, the higher level, the pro athletes get back at a higher level. But then when you look at how well does passing one of these return to sport batteries predict a second ACL injury, if you look at all the graphs together, it doesn't predict it well at all. There's no correlation, basically. It's not a significant correlation. However, if you break the graphs apart, when we just looked at graft rupture, passing a return to sport battery reduced the risk of a graft rupture, which remember is the smaller number. The fewer people tear their graft than their contralateral ACL. It reduced it by about 60% when you weeded out the grafts and the contralateral side. Here's the disturbing part. And again, these are relative risk ratios. So the percentages are large as the relative risk are relatively small. But if you look at the percentage change, your risk of a contralateral tear after passing a return to sport battery goes up 235%. Mm. So in current usage, our batteries for returning people back to sport, say passing and say, you're okay, you're not going to have a second ACL tear, are not good. They're not highly valid, and more work needs to be done. We have to do more work on the side of really looking at these neuromuscular imbalances. So those kids that we looked at, because you have to remember, these are smaller populations. So the data I'm going to talk about is on about 159 kids, because we're looking at kids who've had a second ACL tear. So that rate is relatively low, but we actually have biomechanics and measures of neuromuscular control on it. What we used was what we found out of thousands and thousands of biomechanical and neuromuscular measurements was four things, four imbalances that led into a tear, a second tear. A net hip internal rotation impulse, meaning that ground reaction force is internally rotating and adducting the hip. So whereas those who are actively using their hip and glute musculature to externally rotate and abduct their hip and keep the hips and knees squared didn't have an increased risk. Those who had a net internal hip rotation moment impulse at landing off a drop vertical box jump had an 8 times increased risk of a second ACL tear. That 2D valgus motion at the knee, that medial drop, those that went on to a second tear had a 3.5 times greater risk of having a second ACL tear. A big difference in the amount of quad to hamstring activation, and especially leg dominance, symmetry in that. So individuals that on their involved side are really decreasing their quad activity, but on the other side have higher quad activity to hamstring and have a big asymmetry in that, they had a 3-fold higher risk of tearing the ACL the second time, having a second ACL tear. And finally, those individuals, we put them on an unstable platform and measured the amount of sway on an unstable platform. And those that had a real stiffening pattern, they don't really sense that joint very well because they've lost those mechanoreceptors in the native ACL and they don't have good kinesthesia, joint position sense, good overall proprioception around that joint. So they stiffen it, they decrease the degrees of freedom of motion and control. They had a 2.5 times greater risk. If we put those 4 factors together, that model could predict who was going to have a second ACL injury with about 90+% sensitivity and specificity. A very good model for risk stratifying individuals who are going to go on to a second tear. The challenge is those are based off 3D biomechanical, neuromuscular measurements and unstable force platforms. So it's harder to do. But that's a better way to go, but we have to take that further to make it more clinically applicable and more generalizable to large populations.
Mm-hmm. Hear the entire episode for free on iTunes, Spotify, other favorite podcast players, or go to mechanicalcareforum.com.